Once again, welcome to Medicomello. Today we are going to discuss the practical proforma of the respiratory system from the general medicine. First of all, we start with the general examination. First, we have to look the build, that is the skeletal framework and the nourishment of the patient. The nourishment is regarding the muscle mass and the fat. And we will write as moderately built or nourished, or like poorly built and moderately nourished or well nourished. Next to the physical attitude, that is while we are examining the patient, how the patient sits, that is whether he is sitting or stooping, standing, or whether he is in supine position. Next, we have to look at the pallor, icterus, cyanosis, clubbing, and lymphadenopathy, and also the edema that we have to note. Next is the skin, hair, nails, and general appearance of the patient, and most importantly the vitals, that is the pulse. We have to define the pulse rate, the rhythm, the volume, the character, etc., and the BP, blood pressure, and the respiratory rate, and the temperature of the patient, like the patient is febrile or afebrile. After the general examination, next is the examination of the upper respiratory tract. We will complete it very fastly during the examination, like inspection and palpation as a whole, we do it together. Inspection, the nose, nostrils, and the vestibule, the nasal mucosa we will inspect. We will check whether there is any deviated nasal septum, that is the DNS, whether there is discharge or any obstruction. And also the oral cavity we will inspect. The hygiene, whether there is any dental caries, tonsils, and mucosa we will watch, we will observe. And also the palpation, the paranasal sinuses we will touch, we will palpate whether there is any swelling, and also we'll check the tenderness. Tenderness we check in the frontal sinus, maxillary sinus, and ethmoidal sinus. And we have to check for the DNS if we are having time using a glass slide or any steel tongue depressor kept beneath the nostril. And coming to the examination of lower respiratory tract, the position, we will keep the patient in the sitting and supine position, and most of the examination is done with sitting posture, and in supine posture we will watch from the foot end to view the chest expansion, that is to compare the both sides of the chest, that is left side and right side, whether they are moving, expanding the same level or not, that we will compare from the foot end. And in supine position, this is the main examination what we are doing. Regarding the inspection, first of all, the shape of the chest we have to observe whether it is normal or any barrel-shaped chest or pigeon's chest. Barrel-shaped chest is seen in COPD and emphysema patients. Whether there is any kyphoscoliosis or any drooping of the shoulders, that we look from behind. And drooping of shoulder, we will watch whether at the lower level of the shoulder, the shorter the spino-scapular distance and more prominent the medial border of the scapula. At the side of the drooping of the shoulder, the prominent medial border of the scapula, and also the vertebral spine and the scapula, the distance will be shorter, and it confirms this drooping of the shoulder. And next is the position of the trachea. The trail sign is seen is done in the palpation. Here we just observe whether the trachea seems to be central or any deviation is present. Then respiratory movements, the chest expansion we have to inspect, that we have discussed. The rhythm of the respiration, whether it is regular or irregular, and there are many examples and types of the regular and irregular rhythms. Type of breathing we have to observe, whether it is abdominothoracic seen in males or thoracoabdominal in females. We have to check whether a supraclavicular hollowing is present, any intercostal retractions are seen, whether the patient is using any accessory muscles for the respiration, like sternocleidomastoid or any abdominal muscles. We have to check any dilated veins are present or there is any pulsation visible, and also check for scars and sinuses in the chest wall. Regarding the palpation, we have to check the position of the trachea, and that's the trails sign comes in, the 3-finger test. We can check with the prominence of sternocleidomastoid on same side of the deviation. That is, if there is any deviation, at the same side of the deviation, the sternocleidomastoid muscle will be more prominent. And also we can check with insinuating 3 fingers between the trachea and the sternocleidomastoid and check for the depth or the cavity between these two. So more the depth or more the cavity, more distance between the trachea and the sternocleidomastoid, and hence it is deviated to the other side. So right side deviation is normal in some patients. The deviation indicates it is to check whether any mass or collapse of the lungs is present, or to check or rule out any pneumothorax or fibrosis, like etc. And next we have to look the apex beat. Apex beat is difficult to palpate in COPD or emphysematous lungs because the lung will be expanded and the heart will be situated more deep, and hence difficult to palpate the apex beat. Next is the respiratory movements we have to palpate. This is how the upper anterior chest wall movement is evaluated. We have to keep the hands like this, the palm in the infraclavicular fossa with the thumbs horizontally and kept close together, and the anterior posterior movements of these two thumbs are compared, and hence these two sides of the chest wall, their movements are compared. Next is the lower part of the anterior chest wall. We have to keep the hands below the level of the nipple and thumbs horizontally, and we have to check how far apart or how equally the thumbs are moving apart, and that gives the comparison between the two hemithorax movements. Next is the posterior wall, upper posterior chest wall. We have to keep the palm like this in the shoulders, just below the shoulders on the scapula, and with the thumb extended vertically upwards, and the upward movements of this thumb are compared, and hence comparing the two sides of the chest wall. And the lower part of the posterior chest wall, we have to again grab the chest like this and keeping the thumbs horizontally, and the lateral movement, that is the thumb moving apart, are compared, how far and how equally they are moving, and hence comparing the hemithorax movements. Next is the chest expansion we have to measure. We have to measure using a tape, and in males we have to keep the tape at the level of the nipples, in females below the level of the nipples. The total expansion usually 3 or more centimeters in males in normal, more than or equal to 2.5 centimeters in female is normal. If it is lesser, then the chest movement is reduced, that is the expansion is reduced. The differential expansion, that is the hemithorax movement that we can measure with one end of the tape fixed at the vertebral spine and the other end kept in the sternal margin. We are asking the patient to inspire and after expiration, and thus the expansion is measured. Next is the vocal fremitus. We have to measure it simultaneously with the ulnar border of the palm, asking the patient to say like 1 1 1 1 like that. Increased vocal fremitus can be seen in consolidation. Decreased vocal fremitus is seen in pleural effusion, pneumothorax, etc. Next, the AP, anterior posterior and transverse diameters we have to measure. The anterior posterior and transverse diameter ratio, it is approximately 5/7. If it is equal, if they are equal, or if the ratio is more than 5/7, it is more suggestive of the barrel chest. Next is the percussion we are doing in sitting posture. In the clavicle and also in the manubrium sterni, we are directly percussing. If there is dullness in the manubrium, it can be a lymphadenopathy in the mediastinum or can be a mass in the mediastinum. In the apex of the lungs to percuss, we have to keep the pleximeter perpendicular to the clavicle, that is at the supraclavicular fossa. Mainly, we have to demonstrate the liver dullness. The liver dullness is located from the 5th right intercostal space at the mid-clavicular line, the 7th right intercostal space at the mid-axillary line, and the 9th right intercostal space at the scapular line. This is easy to remember. And also trough space dullness we have to locate, the landmarks of the trough space that we have to study. In trough space, the dullness can be seen in left pleural effusion, splenomegaly, CA stomach or CA of the tail of pancreas, and even food in the stomach can cause the dullness in the throat space. Next is the chronic isthmus. It is the area of the apex of the lungs. The dullness is seen in commonly pan-coast tumor, and its landmarkings also you have to study. And the results, interpreting the results of the percussion, the tympanic note is seen over the stomach. If the note is hyperresonant, then it is suggestive of pneumothorax. If it is an impaired resonance, it is seen in fibrosis. In consolidation, we get a dull note, and in pleural effusion and empyema, we get a stony dullness. Next is the tidal percussion. It is to distinguish between the intrathoracic lesion or the causes with the subdiaphragmatic lesions. That is, we percuss the liver dullness at the level of the diaphragm, then ask the patient to take a deep breath. In the inspiration also, we will percuss, and again we will locate the shifted dullness, and that's the tidal percussion. And the dullness doesn't shift with inspiration if it is an intrathoracic lesion, but if it is subdiaphragmatic lesion, during inspiration the dullness descends down along with the diaphragm. Usually the dullness shift with a minimum 5 centimeter or a 2 intercostal space shift is seen. So greater than or equal to 5 centimeter is the normal tidal percussion. Next is the shifting dullness. It is seen at hydropneumothorax. First of all, while the patient is sitting, we have to percuss the chest wall and mark the upper border of the dullness, and ask the patient to lie down, and after 30 seconds of supine position or lying lateral to it, just start percussing from the same point, and there we can see the dullness being shifted to a more lower level, and that is the demonstration of shifting dullness, and it is done in hydropneumothorax. And regarding the auscultation, we perform while the patient is sitting. In the anterior chest wall, we have to compare, we have to look out at the supraclavicular area, infraclavicular area, mammary area, inframammary area. In the lateral chest, axillary area, infraaxillary area. Infraaxillary area is the area below the fifth rib. In the posterior chest, we have to auscultate the suprascapular area, interscapular area, and also the infrascapular area. We have to compare simultaneously the both sides. What we are auscultating? First, the breath sounds we have to auscultate. Its intensity we have to look, whether it is normal, bilaterally equal, whether it is diminished or absent. We have to look out the type, whether it is vesicular, which is a normal one, whether it is bronchial or bronchovesicular. If it is bronchial, we have to check whether it is tubular or cavernous or amphoric. It will be a little bit higher level. Still, if it is possible, we have to check it. This is the vesicular type, and it's normal type of the breathing, where inspiration, the whole of the inspiration we can hear without a pause, or about 1/3 of the expiration we can hear. If it is a bronchial breath sound, which is a pathological, the whole of the inspiration can be heard, and there will be a pause, and also few or most of the part of the expiration is also heard. Regarding the bronchovesicular type, it is a combination of the both. The inspiration is heard, and without a pause, the expiration is heard, which is more or equal to the inspiration. Regarding the tubular type, it is a high-pitched breath sound seen at consolidation and also at the upper level of the pleural effusion. If it is a cavernous, it is a low-pitched sound and seen typically in a cavity. If it is amphoric, it is also low-pitched, and it is seen in bronchopleural fistula and also in cavity which is communicating with the bronchus. Also, we have to auscultate for any adventitious sounds like rhonchi or crepitations. Rhonchi are music-like sounds, whereas creps, it can be a coarse or fine. Coarse crepitations are seen in bronchiectasis, whereas fine crepitations are typically suggestive of pulmonary edema. And also vocal resonance we have to look. Vocal resonance we have to simultaneously check with asking the patient to say like 1-1 or 2-2. It can be normal, it can be decreased or increased or absent, and that we have to compare with both the sides. And finally, Some miscellaneous sounds, if we are getting, we have to note. It can be a bronchophony. What is bronchophony? Individual words or syllables, usually it will be distinguishable, but here it is not clearly heard. That is bronchophony. Egophony, like asking the patient to say E, 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 it is heard as A. And whispering petrology, the whispered sounds, usually they are not heard properly or they are indistinguishable, but here it becomes clearly distinguishable word by word. And these are seen in like consolidation or some case of pleural effusion. Pleural rub, which is a superficial scratchy leathery sound typically seen in pleuritis or pleural inflammation. Coin sound heard during the coin test. It is normally not conducted. What we are doing is we are placing a coil in the upper level of the pneumothorax, and we are tapping it with another coin, and just opposite to that we are placing our stethoscope, and we will be hearing a metallic ringing. It is heard in pneumothorax. Usually it is not heard in a normal lung. Succussion splash, which is demonstrated in hydropneumothorax. We are placing the stethoscope at the air fluid level, and we are shaking the patient with the shoulder at the level of the shoulder, fixing the opposite side, and we will hear a succussion splashing sound. And also post-tussive suction. It is seen at a cavity, and we can hear amphoric or cavernous breath sounds. And this is a short revision of the practical proforma of respiratory system. And thank you.